Well, my name's Mervyn Morgan. I'm from the ITP Support Association. With us today, we have the pleasure of the company of Dr. Catherine Baggott from Glasgow Royal Infirmary. Welcome, Catherine. Thank you as always.
I apologise that I have an odd name and I haven't worked out how to change it yet, and I try and do it and I forget. So yeah, so I'm Catherine. You can call me Baggy if you want, but that's
you're the one person, Catherine, when that name comes up, I know exactly who it is. So, also like to welcome, many of you would also know her as senior patient mentor, Mrs. Rhonda Anderson. Also one of the association's trustees and a member of the European Patient Committee on the EHA, Mr. Derek Elston. And
Evening,
another
everybody.
board member, evening Derek, and another board member from the association, Anthony Hurd. Welcome, Anthony. We've got a few questions. I know Anthony had a great one, and it's worth covering. I think, Anthony, do you want to ask a question?
Yes, it's it may be a reflection really of some of the questions that have been asked on social media. And I've seen quite a few people raising the issue. It's about what level of protection, have we any idea what level of protection any of the COVID-19 vaccines give to those of us who are on immune suppressing drugs? So I know that the universities of Glasgow and Birmingham were looking at this very area, but I haven't read anything subsequently about any of their findings or even if they've got any further with it at all. So I know it's very difficult to estimate because whatever happens, we're all different. So we'll all no doubt respond differently to these things. But it was just really to get a general, if we could get a general guesstimate really, if anything, on what level of protection it might offer for those of us who are immune suppressed.
Yeah, so that's really interesting. So a letter's come out from Gregor Smith, the Deputy CMO today, which I don't know if it's been issued to patients yet, but it is for patients, talking about, it's not referring to patients with ITP who are, say, on steroids or immunosuppression. It's very much for those that have got solid organ transplants or are on chemotherapy. So people who are really, really immunosuppressed, but it's basically to give some reassurance and some guidance, because shielding is not going to be brought back, to just give some guidance to patients. And I think, therefore, when this letter comes out, and I'll need to check, but I suspect I can probably share it with Mervyn, because it is going to be a publicly available letter, but I only received it today as a doctor. But it is going to go out to definitely to every patient who has shielded in the past. So it will apply to some ITP patients, because I know that some ITP patients will have been asked to shield before. So there's that. And then the other thing to say, just today or yesterday, the UK ITP Forum, and Mervyn, I don't know if you're aware of this, have now finalised their guidance to ITP patients about all things COVID, whether it be COVID disease, COVID vaccination, ITP with COVID vaccinations, and that is, I believe, I haven't looked at actually gone to the website, I've just seen the document. I believe that went up on the British Society of Haematology website yesterday. Okay. And again, that's publicly available for everyone to look at. I can't remember all, I can't remember all the figures off the top of my head, but there's no question that everyone is, almost everyone, obviously you can never say 100%, but pretty much everyone is advised to get the vaccine. There's no question about that. And yes, it may be associated with a slight increased risk of ITP, new or a relapse, but that risk is completely outweighed by the benefit. And that risk is associated with any COVID vaccination. It appears to be at the same level as other vaccines such as MMR. So those are those two documents that I think are incredibly pertinent to your question, that have come out literally in the last sort of 12 to 24 hours, so hot off the press. I think that there's no question that if you're on some form of immunosuppression, your response to the COVID vaccine will not be as good. No. But I think it's very reassuring that levels do get pretty high in terms of protection once you get your second dose. And it's certainly better than no protection at all,
Yeah,
which is why I think it really is it'd be mad not to get it. Obviously, it's always a personal decision, but you know, I really can't recommend it strongly enough.
Okay, thank you for that. Another COVID type question, vaccine type question, was from Graham. Graham, you're on mute. Do you want to ask your question?
Yeah, hi. Mine might be a bit of a personal case in some respects, because it's been a bit of a comedy of errors and miscommunications with my health board. But I'm in Scotland. I received I'm in Fife. I received 1 dose AstraZeneca, and I never had it confirmed, but I had all the sort of rash associated with it. Very much as if I ended up with a mild case of ITP as a result of my first dose. Now, my question, I suppose, is would I be advised to switch to the other brand? Now, that the answer might well have been no. It's not really. The second dose is associated with much less side effect than the first. But unfortunately, my comedy of miscommunications has meant I've pushed well past 12 weeks between doses. So I guess the question is, what would be the general advice in that situation where you've run out the clock, but you're desperately trying to get vaccinated again, but avoid the risk of ITP, which, as I understand it, repeat exposure to this kind of thing could be problematic.
Yeah. So I think there's so much we don't know. I think we don't know for certain whether your ITP will relapse with second dose. I think a lot of the data that's coming through does seem to suggest that the first dose is the most important in terms of side effects such as ITP, but I don't think we absolutely know hand on heart that there might not be a relapse with the second dose. But having said that, even if someone does have a relapse of their ITP or develops new ITP with a COVID vaccine, we still strongly recommend you get the second dose. Now, whether that should be with a different type of COVID vaccine, I think there's just not enough evidence that will make a difference. You know, that if you say developed ITP or had a relapse with ITP with AstraZeneca, that if you get the second dose with Pfizer, that you're any less likely to relapse or not. So we're not saying you have to have a different type of vaccine at all. One thing we do know is that if you swap between doses, there's much more chance of what we call reactogenicity. So anyone here who had the AstraZeneca vaccine, not everybody, but loads of people who got the AstraZeneca vaccine, felt a bit rubbish for 24 hours. And some people felt a lot rubbish. Nothing serious, but you had a really bad headache, a fever, and you felt grotty. And we know that if you mix up vaccines, that grottiness, if you like, is generally much worse second time round. So it's not serious, but the grottiness is worse. So, and that's really all we definitely know at the moment. The whole thing about will you get better immunity if you swap doses? Are you less likely to get things like ITP if you give a second dose? We just don't know yet. So, as I said before, I think it'd be worthwhile everyone, and Mervyn, you could certainly advertise this, is the ITP guidance on the BSH website. I believe it has been posted. I'm sure it's been posted, actually. I think it went up.
I'm just trying to find it now. I haven't found it yet, but I'm trying to find it now,
so Graham, I hope that helps. I mean, as I say, don't worry that it's been more than 12 weeks. Just drop in, find out where your local drop-in centre is and have the vaccine.
That's great.
Okay, and Nicole's just put something on her question. Will the information the doctor referred to in her answer, the first question, be available on the website? Well, we will be publishing the video.
Mervyn can find it. With regard to Gregor,
if I can find it, yes, it will.
With regard to Gregor Smith's letter, I may need a bit of investigation to see whether that is something that could be shared, because I think a lot of patients will find it very helpful, but not every ITP patient will get it.
Yeah. Okay. Right.
But I'm from the Netherlands, so I'm probably won't get it if I'm because I'm.
No,
not...
you are.
No.
If Dr. Baggett can actually, get consent to actually share it with us, we will publish it. Okay,
Yeah,
and
yeah.
then
I
you will
think
have
because
contact.
it only refers to Scotland as well.
Yes, yeah,
It only refers to
yeah.
Scotland. Now, it
Yeah.
could be that the CMO, Chris Whitty or Van Tam, have done a similar document. I don't know, but I just saw the letter from.
They haven't as yet. No, they haven't as yet. But I know I touched base with Adrian Newland this morning, and I know he inferred about the ITP forum stuff. So.
Right.
But I just haven't had a chance. I can't find it yet. So anyway, we will find it. So yeah. Okay. Any other questions, anyone? Someone must have a question. Patricia. You're on mute, Patricia. You're still on mute. Down the bottom, Patricia, bottom left. There's a little
I've got it
microphone.
now.
That's it.
Yes.
Got it. Okay.
Well, apparently there's no IVIG left anymore, practically in the whole world, because no one's given blood, and so I can't have that anymore for my ITP. So it's going to give me Revelade, the electron backpack, and I looked through. Well, I'm going to start, but I've looked through all the side effects and the dietary, and so I'm scared to take it. But also, then you've got to be 6 hours with food without any calcium in or vitamins or anything. So they suggest at 6 o'clock in the morning, take first pill, and then so that takes care of the first 4 hours. Then the next 2 hours, we can't have any milk products or calcium. And I just wondered how other people have been managing the food, if any of you are on that at all, because it seems a little bit difficult to manage all this.
I mean, does anyone rather than me want to answer that if they've got their own personal experience before I say anything?
Can I come in and answer that from my perspective? I had Avatamapag 6 years ago.
Okay, so nobody's on it then.
We can't hear you, Derek. You're very crackly. Yeah.
Oh, crackly. Hang on, I'll try these. Any better?
That's better, mate. That's better.
Right.
Libby, when you move your iPad, you just put yourself on mute because the noise was coming through. Thank you. Go on, Derek.
I went on to Avatamapag 6 years ago when I was having surgery, and I took it last thing at night, 11 o'clock, with quite a long time after evening meal, so no calcium, and then of course no calcium till the following morning, no problem, and you don't get the after effects of not feeling brilliant to begin with. So I'd suggest you try that, Pat.
Yes, see, I'm a cheese freak. I love milk and everything. So I like.
So do I.
Yeah.
So I thought, well, can I not even have a cup of tea in the morning? But if I wait till the evening to take it, then that's 4 hours. I have to go without any calcium products, milk, vitamins, or anything like that. And that seems such a long time for me to wait. So I thought the 6 o'clock in the morning one would be best. Then my 4 hours is past while I'm.
Well, there's a couple of ladies with their hands up. There's the lady with the glasses first, and I won't say your name, but it says Baldy.
Betty. Trying to unmute.
Go on,
Can you hear me?
far away. Go on.
Yes, I take Avatamapag or Revelade, and I take my tablet in the morning, and I have my cereal at lunchtime because I like the milk and the cereal. And in the morning, I have an egg with toast without any butter, and that's fine for me, and fruit. And I have herbal tea, so that's fine. It works out fine.
Thank you.
Great stuff. Thank you very much. What is your name, actually, madam?
It's Betty.
Betty. Okay.
Alder. Yes.
Betty sounds better than what you got on the name. For it. Right. Libby next, and then Tina. Okay, Libby.
I took my lead off one of your previous meetings and actually take it in the middle of the night. I try and eat
Yes,
nothing
that did come up, yeah.
9. If I eat nothing after 9 o'clock, then you can eat anything after 1:30, 2 o'clock in the morning. You can take it then, and then you're fine for breakfast in the morning if you want it.
That's a good idea.
Yeah, that did come up, didn't it, in a previous meeting?
Yes.
Yeah.
If you get up anyway, then just take it
Get
then.
up for the loo.
Yes, exactly.
Mm.
All the birds, whatever.
Yes, yeah. Okay, Tina.
I was on it briefly and I found that I had my ordinary cereal, but I had it with orange juice instead of milk. And that's actually really rather nice. And you're getting a bit of vitamin C as well. And I have black coffee. So you've just got to get yourself onto black tea, black coffee, or hot water. If you're getting on a bit, you probably, like me, just like hot water.
Yeah, I like water, yes, but cereal's got all kinds of vitamins that they've stuck in it, hasn't it?
Not calcium in Rice Krispies, because I checked it.
Mm.
And you've got to watch out. There's other things as well. It was things with was it 2 cations or something? I'm sure Dr. Baggett.
I can, zinc, I think, is one of them.
Yes,
Yeah.
it's
And
anything
there's something
down
else,
that
yeah.
bit of, yeah.
So yeah, you do have to have a little look at that list, and I can never remember. I know zinc's one of them. It's basically these heavy ions that you have to be careful of. But calcium's a definite one. I mean, there is obviously the elephant in the room is obviously Avatamapag, which
the alternative,
which got SMC approval a month ago. Now, your health boards may or may not have got it yet. Has everyone heard of Avatamapag? Because Avatamapag is basically brother of Eltrombopag, but it doesn't have the dietary restrictions.
Oh.
And Eltrombopag can cause some liver inflammation in some patients. It's not serious, but it means you have to stop the medication. And Avatamapag appears not to do that either. Now, I don't want you all to jump off your Eltrombopag and rush to your hematologist tomorrow and say, can I have Avatamapag, please, because it's brand new. And it was only 4 or 5 weeks ago that I had to prescribe Avatamapag for a patient and had to put in a special request. And, we've had to jump through a few hoops to get the supply. So I don't know where health boards are in terms of getting it. I know Grace Glasgow and Clyde is in that process. We've just got it approved by our therapeutics committee in the health board. And so relatively soon it will be something that's as available as Avatamapag, but it's just be a little bit cautious about jumping in and saying I definitely want it. But as someone who's struggling with the diet, Avatamapag is definitely some hope for the future, because I know that I've had some patients that just cannot take it because cheese and milk is everything to them, and they just can't stick to it.
Yeah, the SMC guidance, I think, only come out on the 8th. It was published, wasn't it?
Yeah,
the embargo
it's very recent. Very recent.
Yeah. That's fine. Okay. Any other questions, people?
Just is Eltrombopag coming out of its protection so that it would get cheaper to use?
Very good question. I always remember Romiplostin came out in 2012 and Eltrombopag wasn't much after it. So let's say 2014. I think most of them have got 10 years, but I'm not absolutely, I think it is 10 years for most drugs.
It is, yeah.
So it won't be, because you're absolutely right. When Eltrombopag comes off patent, because all these drugs are quite pricey, that could influence the market hugely. I don't know, but it is going to be about 2023, 24 if we're saying it's 10 years.
I'm sure I read somewhere the States was coming off it, or was indeed off it this year.
Right. That would make, as I say, we could have been slightly behind the States. So yeah.
Good stuff. Who else has got a question? Anyone? So regarding all your vaccines, all of you have had both doses, yeah? And what about, Catherine might know this. What are the plans, Catherine, for a possible booster dose?
So I don't know. That nothing has been officially announced or in the medical world been announced. You hear a lot about boosters starting in September. which is only 2 weeks away. But I'm not aware of any definitive plan. But I'm sure all of you have heard they've talked about the over 50s receiving a booster. But I don't think there's been any detail about what type of booster you would get. So, you know, as I was just talking about reactogenicity, you would think that maybe they might say you should get the same one again, but have we got the supplies for it? I'm afraid I don't have any insider information with regard to that.
And the vaccination centre I help out at have been told to start preparing for issuing booster jabs probably the second week in September.
Right. But is that in England? That's in England, is it though?
That's in England, yeah. But the strange thing is they're doing away with all the current vaccination staff who are doing it and getting the pharmacists to come in to do it. So very strange, very strange. So yeah.
So it is going to be a very big task to, whatever it was, 25 million, I think, over 50s to vaccinate, along with 25 million flu vaccines. So it's a lot to think about. But yeah, I don't have any more details.
Okay. Okay.
I was told by the nurse at my doctor's surgery some time ago, I must admit, was that if you had the AstraZeneca first, then you would be getting the Pfizer as the follow-up, as the booster, and that the doctor's surgery couldn't actually do the Pfizer because they didn't have the fridges that were suitable. So she said that people would actually have to go to a vaccination centre where they're all set up for that. Now, whether that's still true or not, the other thing that I heard was that they are going to do the vulnerable first, as they did before, supposedly. They did that before. And I also noticed that when you asked if everybody had been vaccinated, Mervyn, that some people shook their heads. So I don't know if they've got questions or they want to talk about their reasons. I mean, I know this is very personal. This is very personal. You don't have to share anything you don't want to. But if you do, or if you want to ask a question about that, then this is probably the moment to ask.
Is there anyone who...
We've got some hands up.
Go ahead, Rona. You're on mute, dear. Thank you.
Hi. Yeah, I'm only 18, so I obviously kind of missed the time to sign up for the vaccine. And at my specific centre, there were a lot of people, like the question that they were getting asked was if they had any, I think it was like blood disorders or bleeding disorders, and someone that I know had ITP once when they were a child, and they told them that, and they were like really hesitant to give them a vaccine, so I held off on signing up for it. But is the recommendation from you that I should go ahead and get both doses?
Yeah, so if I think they do ask you whether you've got a bleeding disorder or not. And so you should say, you know, I've got ITP. We don't have a cut-off platelet count for getting the vaccine. We say that anyone, even if your platelet count's 0 and you've got bleeding problems, you can still get the vaccine. But we do recommend that if your platelet count's less than 30, that you just press on it for a couple of minutes afterwards. They always make you sit in a chair for a bit. Just while you sit in that chair, you don't rub it, you just press it. It's a very, very small needle, but it does go into a muscle. But the thing about ITP is that because the platelets are involved, if it's going to bleed, it bleeds very fast. You know, it bleeds. I don't mean that it bleeds a lot. I mean that if it's going to bleed, it happens quickly. So if you press for that first couple of minutes while you're sitting in the chair, if you haven't got a bruise by that point, you're not going to get one, because platelets work they're the sort of initial stage of the clotting process. And there's lots of other disorders around where you shouldn't get a vaccine or shouldn't get the AstraZeneca vaccine. So it's really important that it's clear that it's not your responsibility, but really say, you know, I've got ITP. I know I am allowed to have the vaccine, because if any of you have heard about something called VIT, or vaccine-induced thrombosis and thrombocytopenia, that syndrome does have thrombocytopenia in the title. And I worry that some people might get missed, because if you've had that, you're not allowed the AstraZeneca vaccine again. But if you've got ITP, as I say, you can have any vaccine. and the benefits of having the vaccine completely outweigh the risks.
But
So,
as Rona's under 40, she will have either Pfizer.
You'd have Pfizer anyway. You'd have Pfizer or Moderna. Yeah. So the AstraZeneca wouldn't come up at all. But I think, having been quite involved in the COVID vaccine because of this thrombotic syndrome, I have absolute admiration for the vaccine staff, because they're being bombarded by thousands and thousands of people every day, and they've got to make a judgment call for every single one. Is it safe to give the person the vaccine? And they're given sort of crib sheets, and you probably see them with their little iPads asking all these questions. But anything that twitches them slightly, someone says thrombocytopenia, and they know there's this thing with thrombocytopenia. I mean, they should go to their vaccine coordinator and everything, but I can really see how it's easy to get worried, get confused, and the patient gets worried and confused and then doesn't get the vaccine. I don't think that happens very often, but I just have such huge respect, because I had my vaccines, I think, by a physio and a speech and language therapist on each occasion, you know, because they were brought in and trained to give the vaccine. So yeah, so don't give up, Rona, go back.
Okay, yeah, I just
want ITP, I can have the vaccine. And if the platelet count's less than 30, press for a couple of minutes.
Great.
Thank you.
Okay, Graham, you got your hand up? Graham?
Yeah. Hi. I thought I'd just share why I hadn't had the second in a little more detail, if you thought that was useful. And it seemed relevant to the forum, because I actually think, conversely, medical professionals had me confused and assumed that I was talking about VIT when I was kind of raising my concerns about the ITP that I'd suffered. And it was actually quite difficult to be heard. Well, it still is actually, it's still ongoing, unfortunately. It was quite difficult to be heard that, you know, no, I wasn't complaining that I'd had a CVT, but I just had these symptoms that I'd quite like explained, and if you know, whether that would help me switching brand or whatnot, which obviously you explained very well just here. But just to be able to hear that is something that my health service hadn't been able to provide. So that explains why I'm only 50%, and thanks to this conversation, why I'm be hurrying up and getting on with it as soon as I can.
I think it's really, really tricky. So this VIT that we're talking about, which is a very serious condition, but it's a very rare condition where you have serious thrombosis along with thrombocytopenia. It's only affected, well, we're not absolutely certain, but probably around about 300 or 400 people in the whole country, despite the fact we've used the AstraZeneca vaccine, I don't know, probably 27 million times now. I don't know the precise figures. And so although we've done our best as haematologists to try and spread the word amongst our haematology colleagues and spread the word amongst all people meeting patients at the door, what we sort of call frontline staff at hospitals and GPs, it's a very rare phenomenon. So although, you know, my world may be saturated in it and I know a lot about it, the vast majority of medics out there don't. And it's had to be passed on to all these vaccine staff, as I say. And so there is always going to be this veering on the side of caution. So I think, you know, this is why I think these forums are good, because I can now say to you, you know, just say, I've got ITP, I haven't got VITs, I know I haven't got VITs. Because I think I can't imagine how the vaccine staff, when it all became public, which was I think the 7th of April, I cannot imagine what it was like for the vaccine staff the following day, just trying to get on top of the information they had. But I can't, they do such a good job.
Because I believe, Graham, your first vaccine dose was way back in April, wasn't it? So it's way over. So
yeah, it is way over. Yes, it's as I say, it was actually sort of the opposite of that scenario, because I was quite happy I hadn't suffered VIT. No one else believed I'd suffered VIT, but I think there'd been a lot of miscommunication, and it had been kind of passed up that I'd been that was my concern, rather than a kind of rather more mild concern that I just wanted checked out. And so it was quite difficult. I was in the position of having been, I think, cast as somebody who was maybe crying wolf a bit.
Oh, shame.
The interesting point, though, Catherine, is that Graham had the AstraZeneca vaccine back in April, but he is under 40. So if he had to go back now, would they decide to give him the Pfizer?
Well, the official line is he will get AstraZeneca. But don't hold me to it. That's what's supposed.
Okay.
The guidance was that if you, because the guidance changed over that period of April to May, first not for the under 30s, then not for under 40s, there sort of had to be this decision making. Well, what do we give all those under 40s who've received AstraZeneca already? And because it seems that it really is incredibly rare, if it happens at all, for VITs to happen after the second dose, that if you've had and because you've got this reactogenicity where you feel more poorly with the second dose, we say that if you have been, if you didn't get VIT with your first dose of AstraZeneca, then you're safe to get AstraZeneca second time, even if you're under the age of 40.
Okay, thank you very much. Right, Kirsty, then Rona. Kirsty, you got a question? You got a hand up?
Yeah, I've got. This has nothing to do with COVID. Yay!
Thank you.
I'm wondering, I was diagnosed 11 years ago and I have not seen a haematologist since. Is that normal?
Well, I don't want to sort of get personal, but it all depends on what your platelet count is. Because certainly
how would you know what your platelet count is? Because nobody asked you to find out.
Okay, so so I certainly have a lot of patients who, and this has certainly become much more of a tendency during the pandemic as well. I think patients and doctors sort of expectations of things have really changed. So certainly before the pandemic, if I had a patient who had a platelet count of greater than 50 and they'd had it for a long time and they were off treatment, then I said, look, you can go away. You don't need to see me every day, because the amount of stress it can sometimes cause patients waiting to find out what their platelet count is when they see me every 6 months. A lot of people have stated that to me. So I will say, go forth, be fine, don't worry about it. If you bleed, call me and I'll see you. Or if you're going to have major surgery, let me know and we'll get a check platelet count. We're moving to, we didn't even have this expression before in our health board, and I'm sure they're bringing out in other health boards in Scotland, there's something called patient initiated review. So rather than you having to go through your GP, so you may be discharged, but rather than going through your GP, if you've got ITP and you suddenly start having nosebleeds and you've never had them before, you can go directly through to your haematology department and say, I used to be looked after by Dr. Baggett, and I can say, right, we'll get a full blood count done. So I'm not saying you've gone through that sort of process, but that's so if you're worried, go to GP, get a full blood count checked. And if you're not worried and you're not bleeding, then don't worry about it. If you
I personally go and get my blood checked at the GPs.
Oh, right.
I personally do that, but I've never seen a haematologist since the day he diagnosed me.
Right. And
which I find very bizarre, because sadly, my son was having issues with his blood results, and he had two blood results whose platelets were low. And the GP surgery were away to test them for a third time, like a couple of months later. And the only doctor in our surgery that is well versed with ITP phoned me at home, and she went, what are they doing? I went, I have no idea. But you and I know where this is leading. So she had already written a letter to the paediatrician and spoke to them, and we got the appointment, and he's now been confirmed. Sadly, he also has it. So I kindly gave him that too.
Well, it's not. So we have a thing about autoimmune conditions is that, so ITP being an autoimmune condition because you break down your platelets when you shouldn't do. There's no like genetic inheritance of things like ITP, but there may be tendencies in families to have these autoimmune conditions.
Yeah, because they took extra blood. When he went in to be diagnosed, they took extra blood, which is a way to be whatever they're a way to do it in Aberdeen.
Yeah, so I don't know exactly what they'll do, but so as far as I know, we haven't proved this, but we just know. So there's some we have proteins on the outside of our white cells, on the outside of all our cells actually, and some of those proteins on the outside of the cells give you a tendency to autoimmune conditions like ITP and other conditions. And these HLA types run through families because you inherit HLA types from your mum and your dad. So it doesn't mean that if you pass on a particular HLA type to your child, they're definitely going to get ITP or some other autoimmune condition, but it just means that tendency is there. So I don't know.
I mean, Dr. Taylor said it was quite unusual.
Yeah. Oh, it's not exactly. It's not common, but
no, he said that it's quite unusual that we've both got. It's not unusual to have the autoimmune. It was the fact that we both have ITP. It's like, which is quite handy technically because my son has got Asperger's, and the fact that I also have ITP means that he doesn't have to think about it, doesn't have to do anything about it because mum knows everything about it, so it's fine. Mum will know if things aren't right and blah 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 the rest of it. So that's kind of, and it's quite funny because his platelets are much lower than mine and he doesn't bruise, opposed to me, I'm a peach. So it just shows you the total difference, Ken. It's just so weird. But it was quite funny because when Dr. Taylor said, obviously with your son's 16 now and he's left school, so we're going to pass him on to adult services, and oh, this is going to happen and that, and I just burst out laughing. He says, why are you laughing? I says, because I've never been seen by adult services. I says, and I'm 11 years in and I've not been seen by anybody. I says, so I would suspect it'll be the same. If his levels are steady, then what's the point? I mean, I know what mine's bounced between something between, I mean, I'm lucky opposed to some of you ladies and gentlemen. Mine's bounced between 70 and 90, and I'm no sitting at low numbers. I've never had to be on anything other than prednisolone before I've had to have a coil change and things like that. But that was like 7 years ago, opposed to this time I didn't need to go through that kind of palaver because the parameters had kind of changed and things. But no, I do make sure that my son has a medical alert bracelet on, the same as myself, so that it is kind of apparent that what he has and things like that.
Because if you suffer, a bad car accident or something, it would be good for the healthcare team to know that the credits aren't absolutely normal.
Yes.
So, but yeah, I mean, I think you should be pleased you're not seeing a haematologist.
I am pleased, but it just makes me laugh. You think, this time, it was just that Odie said it, and Callum will be seen regularly. No, he wouldn't, because if his platelets
it's actually
are stable,
good, Kirsty.
There's no point.
It's actually good, Kirsty. That, you said your GP knows what he's looking at.
Yeah, she does.
Yeah.
She's really switched on.
That's great. That's great.
How we learned that was, now I should have helped a bit more, but I didn't. But when I was away for a coil change 7 years ago, I knew what had to happen in my head because of being on the forum and being on the support group. I knew what should be happening, and it wasn't. They were getting to the point they were going to send me to hospital to get it changed, and I thought, what a palaver! Just for something like that, surely I don't need to go to that extent. So we decided that after 2 months of backing and throwing, I said, could you just check my bloods, and if they're okay, fine, and if they're no, then just go into steroids, which I had to go into prednisolone for a short space of time and get my platelets up and things like that, and we did manage to do it there. But no, she's really clued in.
That's good.
Also, the new dentist that we've got, also very clued in on ITP as well. So quite fortunate in that respect. So yeah, I'm quite happy not to see a haematologist, because sadly Dr. Watson is now retiring, and that's quite sad because he was lovely.
Yes, he is indeed.
Okay, Rhoda, you got your hand up.
I'm sorry, I have a question about COVID.
I don't mind COVID.
Sorry. Yeah, no, obviously just because I'd not been thinking I was like getting it, or I wasn't signed up, so I've not had anyone to ask, but I was wondering if 12 weeks is just the recommended time, or if it has to be specifically 12 weeks, because I'm going away to uni.
Right.
And obviously it'd be ideal if I could get both before I go, but I know that might not be, if I could always come back and get it.
I've got I have to say, I'm sort of quite not confused, but when these licenses came out for the COVID vaccines, it was like 3 weeks apart. That was what was supposed to happen.
Yeah.
And then the UK had a bit of a crisis. We're in the middle of a massive second wave, and the JCVI, the vaccine committee, had to say, right, we've got to get as many people a first dose as we can, as quickly as we can. So they moved to 12 weeks. I now know and I was worried, oh my God, isn't this a bit of a leap of faith? But actually, now I've read bit about it, and I recommend, this isn't ITP, I recommend everyone read Vaxxers, the book by Sarah Gilbert and the team from Oxford. It's brilliant. Anyway, lots of work has been done to show that actually the immune response is actually very good if you extend it out to 12 weeks. So, and I think maybe we had some of that data already, and maybe it just wasn't in the public domain, I don't know. But I think there's flexibility. Mine were 8 weeks apart. So I think it shouldn't be closer than 3 weeks, but I think it should be close to 12 if you can make it, from what I've read. But I mean, I'm not a vaccine expert. But also, if you don't get your second dose until 14, 15 weeks, that is still okay. At the end of the day, you're dealing with clinical trials, and certain things were done in the clinical trials, and that's the only information we've got. And until you've got more real world data, you can't really know exactly how flexible you can be. So if you get your first dose as soon as possible, say to the vaccine centre, I'm going off to uni. Are you going to England, or are you staying in Scotland?
No, Edinburgh, so Scotland.
Oh, that's well, the thing. So don't worry about it. Just when you go to Edinburgh, just
they have like
drop-in centres. Yeah. It won't be a problem.
It will be very way. There be a way for me to guarantee like I can get the same type of or just say when I go in.
It's all on national records, so it shouldn't matter that you're getting the second dose in a different health board. If you're going to England, I don't think they'd have a record of your vaccination status, but I think if you're in Scotland, they will, because it's really common amongst many people, but particularly younger people, that they may well move to somewhere else for their second dose, and that could often be a different country.
I think that's what's happened to a lot of our age.
Yeah, so I actually wouldn't worry too much about it. I know it's the East Coast, which is very different, but it's still the same country.
Okay, thank you.
I know in England, at the vaccination centre, I said that I help out at, we was told last week, if anyone comes even 2 or 3 days shy of 12 weeks, turn them away. They have to be 12 weeks. Yeah, which amazed me, but yeah.
I mean, I've just found it so variable amongst patients, because I can see the immunisation record of every patient. It's on the clinical electronic system for every patient that I see. You can just look up their immunisations now, and it really varies. Some are 8 weeks, some are 10 weeks.
Yeah, very strange.
It just varies.
Very strange. Rhonda, you got your hand up.
Yes, I wanted to ask Catherine, so I think it was Pat mentioned that there's a shortage of Ivig, and I was just wondering if you could tell us what effect that's having on treating patients.
So that's really interesting. So we were warned about this probably about 3 or 4 months ago, that it was going to happen, and therefore we should use it as sparingly as possible. I'm not just talking about ITP now, I'm just talking across the board. But ITP, so the Ivig has always been in short supply. It's been expensive and it's been in short supply, and we've had these forms in Scotland now for 5, 8 years, where you have red indications, blue indications and grey indications, and red indications are the ones where you should definitely get it, and ITP is a red recommendation. So when we knew this crisis was going to hit, and come July we were told that probably, well, it was England were told they were going to run out, but it was obviously going to affect Scotland as well, that we should still be able to get Ivig for red category patients. So I hadn't been overly worried about my ITP patients. I haven't had to give Ivig to an ITP patient recently. I don't have any ITP patients on it regularly, because I know some people get it regularly. I would have been just as shocked as you if I'd got a new ITP patient tomorrow and needed Ivig and they said I couldn't have it, because I wasn't aware that Scotland had reached that absolute crisis point of not being able to receive it.
Well, we've started teaming up with NHS Blood and Transplant, doing a sort of publicity campaign, social media and the website, looking for donors, because they've now given the go-ahead again in the UK that people can actually give plasma again. So I believe there was a whole...
I saw that today on the news, actually. Yeah, because that I don't think it's only lack of donors, though. I don't work for National Transfusion Service in Scotland, but I don't think it's just lack of donors because of COVID. I think there's been other It may actually be processing because of furloughing and social distancing. I think there's a lot of things.
Because it does take a while, doesn't it? Like to create the stuff. Yeah. So we're also doing a joint social media, or planning to do a joint social media campaign, which I need to speak to Anthony about during ITP Awareness Week. We're going to do a joint press release, etc., and all that. You know, to try and raise the profile of it. So no,
that's a good idea. I mean, I think I'm quite shocked, and I will certainly be going back to work tomorrow to make sure that there is IVIG in our health board. As far as I know, there is, but you know, to hear that someone can't get IVIG, you know, was actually quite a shock to me, because I didn't know that we were going to completely not have it for ITP patients.
Okay. Could I ask a question about him?
Go on, Derek, far away.
The plasmas in Europe and in States particularly, the donors are paid. How would you feel about that happening in the UK and Scotland?
That's actually quite easy to answer. Absolutely not. There's a very good book written in the 1960s. I can't remember exactly what it's called, but it's The Act of Something. Anyway, basically, when you give for altruistic reasons, your blood is safer. And so I hope we never, ever offer donations, because so this was the problem in the States in the 1960s, 1970s, is that anyone could donate, they got paid. They were asked questions, have you ever gone yellow? Have you ever had hepatitis? Well, if you're about to be paid $50 to give that blood, you're not going to tell anyone that you've had hepatitis or you're jaundiced, because you need that $50. Whereas altruistic donation, when you're doing it for the greater good of the population, if you're asked, have you had hepatitis? Have you ever been jaundiced? Go, actually, I have, because there's no gain for the donor. So, no.
I would question some of that, but only in as much that the States certainly went through a very bad time in the 60s, and HIV and other conditions came through, and of course a lot of it was coming from the penitentiaries where they were rife. Hopefully now, with modern technology, the processing of plasma is a lot safer and a lot better than it was, and certainly from start to finish, you're looking at about 9 months between collecting and distributing out on the network. And the States have just gone through a very interesting period where the government stopped Mexicans coming over the border to donate, which they've done in hordes apparently. And of course, it was going to have a devastating effect on plasma being available, not only in the States, but in other parts of the world as well. So it's going to be interesting to see how it plays out.
Was it because we was invited to a meeting about this, Derek, wasn't we?
We were.
The average Mexican who donates plasma across the border in the States earns about $4,000 a year doing that one. So it's very strange. Yeah. So yeah. Okay. Libby, you got your hand up?
Yes. Right. On the blood donation thing, can ITPers give blood, or does it depend what medication you're on? And can you ask for it to be turned into platelets or anything? Bearing in mind we
So the priority when blood donation happens is always the donor. So if you've got ITP, they will almost, so I don't know exactly what the rules are. I suspect if you are in remission, well, no, if you're in remission from ITP and you're off all medication, yes, they'll accept your bloods. But if you have a platelet count, if you've got ITP of a platelet count of 70, I doubt they'll accept your blood, not because it's not safe or anything like that, but you, the donor, may get a really bad bruise from having the big needle put in your arm. And so they're so strict about donor safety that you pretty much have to have absolutely nothing wrong with you to be able to give blood. You can always ask. So, but again, if you're on medication, so let's say you're on L-Trombopag, and your platelet count's completely normal, you can ask, but I'm not sure what they'll say. I don't know, actually. You know, it's certainly not a contraindication on you know, if anyone donates blood, you know, if you look, ITP is not a contraindication, but certain medications might be. And it won't be because they don't think your blood's any good. It will be they're worried what the impact of being a donor will be on you, which I think sometimes people who've had blood disorders in the past find very annoying because they sort of want to give back, but they're very strict about donor safety. It's not they're worried you're going to give ITP to someone or anything like that. It's got nothing to do with that at all.
Okay.
Something else to throw into the equation on that, it's if people haven't already done so, it's very much worthwhile looking up and finding out what your actual blood type is and making sure that that is well documented on any medical alert bracelets you have, and any I use the app that is provided by Novartis to record all of my personal details and my platelet scores and so on and so on. So something that probably most people have already done, but if you haven't done, make sure you know what your blood type is and make sure it's registered and that people know about it.
Thanks, Anthony. Tina, you got your hand up, and then Rona afterwards.
Yeah, on a related thing, are people with ITP okay still, I mean post-mortem, to be organ donors, or does it affect the organs?
No, so I mean, not to be morbid about it, but obviously then donor safety doesn't matter. Do you see what I mean?
Yeah.
Sorry, and therefore, as long as you have healthy heart, lungs, the organ that is required, then you'll be able to donate. Yeah. So yeah, there's nothing to stop you being an organ donor at all. As I say, the whole blood thing is all about donor safety. It's not that your blood's no good. Very much.
Thank you.
Yeah.
Thank you.
Hey, thank you, Tina. Rona?
Sorry, I was just going to quickly ask, how do you find out your blood type? Do you ask, or?
Okay, so yeah, so I'm gonna get rid of some myths here, because everyone thinks if they see a doctor, their blood type is known, and it's not true. So you have to have needed a reason. You have to have been moderately ill in hospital or have needed surgery. And it could be quite minor surgery, but they'll still do what we call a group and screen, where they will take a blood sample and have it registered in the blood bank of the hospital in case something unexpected happened at your surgery and you needed blood. But otherwise, there's no reason why anyone would know their blood type, and they're sometimes really shocked by that. I often get patients, sometimes with ITP, so what's a blood group? And go, actually, we don't know. Although generally, actually, ITP is not a good example, because generally we would do a group and screen for ITP in case you had significant bleeding problems. So that's not the best example. But I have other patients where there's no need to check their blood group. So yeah, so I wouldn't worry too much. The other thing to say about, I'm not saying you shouldn't have it on alerts and things, that's absolutely fine. But even if you have an alert on a bracelet that says you're A positive, for example, and you go to a hospital where you've never been before, they've got no record of your blood group on their records, they will not base anything on that bracelet you're wearing, because it's too dangerous. So you will always, you know, it's probably bound to be right, but it's just it's blood transfusion is a very, very safe thing. Giving the wrong blood to the wrong patient is what we consider a never event, so it should never happen. Whereas other medical things can happen even with the best one in the world. It's called a never event. So therefore it's very, very strict. Now, for example, if you're in hospital and you have your blood taken for the first time, it says you're A positive, you have to have another sample taken to prove you're A positive before they give blood. Not that your blood group will have changed, but what if it was wrong blood from patient? It's to be absolutely safe and certain. So, yeah, it's not all of you will have your blood group known, is a short answer.
Okay.
Great stuff. Thanks very much, Rona. Well, we're coming to the end nearly. Anyone else got any questions? Must be one. No. No, right. That's it. Thank you very much, Catherine. It's been a pleasure. Lots and lots of different questions this time, which is really good.
Right.
Lovely to see everyone. You know, some familiar faces here, but hope to see you all again. Just a quick few updates of what's coming on in the next month. we've got ITP Awareness Week commencing the 20th of September. We're kicking that off with the first ever Northeast of England meeting, which is going to be, which is being organised by Tina there. And then on the Wednesday, we've got a paediatric virtual meeting, which is being chaired by Dr. Nicola Cooper from Hammersmith Hospital. And then later in the week, we should be having, and we're in the early stages of planning, a webinar where we're trying to bring in the USA, Australia and the UK in one webinar lasting a couple of hours. Now, we might pre-record some bits because of the time zones. Otherwise, the poor Australians will be up rather late because it won't be us. So we'll see. But yeah, so it's all looking good. And in addition, we've got a document going to be published on the 21st of September that Rhonda's aware of and Derek's aware of and Anthony, called the Shared Decision-Making Document for ITP patients. It's a collaboration between us at the association and the ITP forum, and we're quite proud of it. We just got endorsement last week from the Royal College of Pathologists for it, and I'm after endorsements from Rare Disease UK, etc., and all that. So it's looking good. But thank you, everyone. Hope to see you during ITP Awareness Week, and take care.
Thanks a lot. Bye-bye.
Thank you very much, Catherine. Thank you.
Bye-bye.
Cheerio, everyone.
Wish you all the best.